Yeah, so we'll go on to the perimetry, which is probably not as important as the first talk on optic disc was, but at the same time you must understand when to do a perimetry. So this is important because you would not send a patient who has got healthy optic discs and high pressures for a perimetry, because if the disc is healthy, it's unlikely that you're going to get a defect on the perimetry, right? So we have a lot of residents writing, you know, perimetry for every disc which is absolutely healthy or even slightly suspicious. They will be writing a perimetry, but that's not the way it should go. Basically, you must understand, again, as what she said, is that the structural changes will always precede the functional changes, okay? So what you're going to get on perimetry will happen at least 5 to 10 years down the line after the structural defects have already occurred. So the idea in glaucoma is to pick up structural defects as early as you can, and perimetry is only corroborative evidence. So perimetry is not used for diagnosis of glaucoma, but it is used for confirmation of the diagnosis of glaucoma. Okay, then again it is also used for monitoring the disease. It's important when you have to see how, to what extent is a patient affected by the disease. That's when you want to do a perimetry. And then your therapeutic decisions are mainly based upon what are the actual functional defects the patient has. So these are where perimetry is important. So again, I'm going to emphasize the fact that you're not going to do perimetry just because you want to confirm a diagnosis, okay? Your diagnosis is based upon the high pressures and the optic disc features, and the perimetry will come much later, right? So that you must understand. Now, how do you see visual field defects on perimetry in glaucoma? Again, the anatomy is very important. The entire nerve fiber layer is in an arcuate fashion, and you're going to see visual field defects also in an arcuate fashion. So this you must remember very carefully, that when you're looking for glaucomatous visual field defects, they are going to respect the horizontal midline. They are going to be in an arcuate fashion, right? So this again picture of an arcuate RNFL defect will lead to a what kind of visual field defect? Quickly raise your hands. Superior arcuate defect? Yes? If there is an inferior defect here, it's leading to a superior arcuate defect. Yes? Okay, good. Now, earlier we used to have kinetic perimetry. It is more or less gone out of vogue, but there are certain places where it is still done, primarily when the patient is non-compliant, his vision is not so good. These are the cases where you would like to do a kinetic perimetry, but then this kinetic perimetry taught us about the visual field defects in glaucoma. So the visual field defects in glaucoma were early paracentral scotomas or a cedal scotoma, which joined together to form an arcuate scotoma. The arcuate scotoma enlarged, okay, until only a small island of vision was left, or a small temporal island was left. So this was the classic progression of a glaucomatous visual field defect. But more or less the automated perimetry has taken over kinetic perimetry, primarily because it's objective, it can be quantified. But in order to understand what an automated visual field is, you must know how to interpret a single field analysis, and then when you have got multiple visual fields, you should be able to see what kind of progression has occurred. Okay? Right. So when you are looking at a single visual field, again, you must be very important, you must understand it's very important that the patient understands what he's going to do, okay? What his pupil diameter is, what his refractive correction is, his date of birth, everything has to be absolutely correct. There will be patients who will be bringing you your some visual fields, and then when you look at the visual fields, it may not even match with the patient's name. It may be some other person's visual field. So be careful that that particular patient, those particular parameters, everything is standardized. And now we're going to talk about how you're going to interpret. The three important questions that you're going to ask when you have a visual field in front of you is what strategy was used, whether it's reliable or not, and whether it's normal, and abnormal, and if it is abnormal, whether it's glaucomatous or not glaucomatous, right? Now, you have the visual field that you can divide. This is a classic Humphrey printout, and this can be divided into the first particular area, which is the parameters that you're going to enter. The second are the reliability indices. The third is the total deviation map that you're going to look at. Then the pattern deviation map that you're going to look at. Finally, you're going to look at the threshold values, and then you're going to look at all the other indices. Now, this is important because the name, as I said, is important. It has to match to the patient's particular name, the age, the date of birth at which you have entered, because the computer is going to basically relate to what the age of patient is and what standardized formats for statistical analysis based on that particular age are. How long the patient has taken to do this test is important. And then what is his what is the refractive correction that you have entered. So these all parameters are important. Then the next thing is that kind of pattern that you're going to see. This is a classic. Raise your hands quickly, stand up. Which, how many degrees? It's not 10-2, madam. No, this is 5 degrees. Okay, the central 5 degrees. When do you do central 5 degrees? When is a central 5 degrees to be? Chloroquine toxicity. Okay, when one classic indication of doing a central 5 degrees is to detect a macular change in chloroquine toxicity. Okay. Then you have a 10-2. 10-2, we generally, glaucoma people do it when the patient has got an advanced visual field defect and only a small central 10 degrees is left. You do a 24-2, it's more or less done a lot in the West where they want to save time, they want to do the test easily, the patient fatigues. If the patient is elderly, then again you want to do a 24-2. But classically what is done is a 30-2, right? In our country a lot of visual fields are 30-2. Then we have a 60-2 also. We have a 60-degree visual field also to be assessed. Okay, more or less it takes the entire visual field into account. And then what is this? Raise your hands. This is the Esteman grid. Okay, this is an Esteman grid. It charts 100 points, right? It can be done uniocularly, it can be done binocularly. So patients, when you want to know what is the amount of visual field defect, when you want to quantify it, when you want to give them some disability certificates, you want to give them a license to drive, then in many of the countries an Esteman grid is done. And this is part and parcel of the Humphrey visual field, and you must know that it has a uniocular and a binocular way to do an Esteman grid. Okay. So there are different varieties by which you can do the different strategies. We used to have full threshold, more or less it's gone out of vogue. It's more or less now a CETA standard. CETA standard or a CETA fast that is done, it reduces the time compared to the earlier tests. So what strategy, what pattern you're going to use will primarily be based upon what kind of patient you have. Is he a patient who's already had a visual field done, or is he a new patient, or whether a patient is old, in which case you might want to do a test which is faster. So all of these have to be matched, right? And you have to write what exactly you want. If a patient has poor vision, what kind of stimulus size would you use? If he has 660 vision and you want to do a perimetry, what is the stimulus size? 5. Very good. Ideally we use 3, but for patients with poor vision we use 5. Okay, so the CETA is a basic test, is a basic program which uses a forecasting kind of technology or statistical maneuver whereby the visual field or the software comes to know that if this particular area is defective, then that particular area should be tested more frequently compared to the other areas. So it does the whole thing very quickly compared to the earlier programs. So all of these have to be standardized and have to be constant over time, in the sense that if you've done this particular strategy, you have to repeat the same visual field with the same strategy in future so that you can find out whether the change has been there or not. Then the reliability. The reliability indices are important because it's going to tell you to what extent the patient is cooperating with the visual, or to what extent he's going to understand it. You must also know what is the foveal threshold, which is actually supposed to be the highest compared to the other areas. The total deviation map is this one, and the pattern deviation is derived from the total deviation plot. The total deviation can be influenced by a lot of factors, whereas the pattern deviation is primarily to do with glaucoma. It's going to tell you the pattern, okay, from the total loss, what is the pattern, okay. So if there are, so this is, for example, it will take out -2 decibels from this entire thing and give you values which are here in a pattern deviation plot. So basically your attempt is to look at the pattern deviation, right? That is how you're going to say whether it is what kind of defect it is. And then of course the threshold values. The global indices are basically defined as the mean deviation and the pattern standard deviation. Mean deviation means how much is the total kind of deviation from the normal, whereas the pattern deviation is going to tell us how much are the localized defects present. The visual field also gives you a glaucoma hemifield test. Does anyone know what a GHT is? So a glaucoma hemifield test, what does it do? It compares the superior field with the inferior field, okay? Same points in a particular pattern in the superior and the inferior hemifield, because glaucoma always respects the horizontal midline. So it's always going to compare what is there in the inferior or what is not there in the inferior vis-a-vis what is there in the superior. So that is why GHT comes up, and GHT is outside normal limits, likely to be glaucomatous. If it's within normal limits, unlikely to be glaucomatous, right? Now, what is normal and what is abnormal in glaucoma? If you see a glaucomatous scotoma, it will be defined as having 3 contiguous points which are non-peripheral, or a PSD which is less than 5%, or a GHT which is abnormal. So any of these 3 criteria, the likelihood of it being glaucomatous is high, and however it needs to be repeated on 2 consecutive visual fields. And this is a printout of, my God, bad, very bad. This is a printout of octopus, okay? This is an octopus printout, and this is a characteristic baby curve. Have you heard of what a baby curve is? Yes, and those who haven't, it gives you a y-axis where you have all the mean deviation plots, and an x-axis where you have points from the best to the worst, okay? So these are the points which are good, and these are the points which are bad, right? So it shows you that some points are good, but some points are bad, which means that there is a localized visual field defects, and every red and black or dark color would mean that there is some abnormality there. Vis-a-vis this kind of octopus printout where all the points are outside the normal limits, okay, outside the 95 confidence. So the whole visual field is depressed from a normal person's, right? That is what the baby curve is going to tell you, right? So this is an octopus printout. You should also be able to read an octopus printout just like you do for Humphrey. Right. Apart from glaucoma, the visual field defects in perimetry can be mimicked by other pathologies like a superior BRVO, which can cause an inferior visual field defect. A tilted retina, high myope, can also cause a visual field defect which is present there in the superior quadrant. There could be optic nerve pathologies like, anybody? Optic nerve, pit, very good. This, drusen, or a papilledema, okay? And then of course there could be neurological defects also which could mimic glaucomatous visual field defect. Now I would like you to read, any of you can volunteer, just stand up, the lady there behind, please, just one of you get up, come forwards. Nobody's confident here. What to do? Come forward, come. Does anyone want to read this visual field? Okay. So this is a Humphrey printout, okay? What does it show? Okay, so there is a field defect here, but you're going to look at the pattern deviation plot, okay? Yes? So there are points in the pattern deviation plot which are outside normal limits, yes? All of these are pattern deviation probability points which are outside normal limits, yes? And they are in the Jerem's area. Do you know what the Jerem's area is? Jerem's area is an arcuate area which extends from the blind spot, and then in an arcuate fashion it sort of goes into the periphery nasally, right? So this is an arcuate defect in the Jerem's area, yes? And this is likely to be glaucomatous because there are 3 contiguous points, they are in the Jerem's area, the glaucoma hemifield test is outside normal limits, and the PSD is quite abnormal. So this is likely to be glaucomatous, but then you are going, like you would read any CT scan, you would say, I would like to correlate it clinically. You would like to look at the optic disc, okay? In fact, you should look at the optic disc and then the visual fields, not the other way around. What about this? How many of you think it's glaucomatous? Likely to be glaucomatous? At least you can raise your hands. So, is it glaucomatous? So what you can see is, you can see 3 contiguous points, or no? There are 3 contiguous points. So this contiguity could be either horizontal, it could be lateral, it could be vertical, or it could be oblique contiguity. Anyway, so all 3 are contiguous. They are contiguous with the blind spot. They are in the Jerem's area, yes, and all of them are outside normal. The GHT is outside normal limits. So this could be an early paracentral scotoma. Again, you need to correlate it clinically, and you need to repeat the visual field to actually say that the likelihood of it being glaucomatous is high. What about this visual field? What is this being glaucomatous? What is the likelihood of this being glaucomatous? High, low, bad. Anyway, so there are points here in the center. Okay, what you must look at is the foveal threshold. What is the foveal threshold? What is the foveal threshold? Can you see it? No? It's 17. It's much lower than the other points. Yes? Fovea should have the highest threshold. So if the foveal threshold is low, then there is probably some other pathology other than glaucoma, because in glaucoma the center is the last to get lost. Okay? So that means this scotoma that you see in the center is probably because of some other pathology and not glaucomatous, and then again you want to go back to the disc and the macula to look at ARMD or for any other macular pathology. Again, this is classically a what kind of defect? Altitudinal defect, yes. One hemifield totally gone, right? It can be glaucomatous, but other pathologies also need to be ruled out. So this is a superior arcuate defect. And then you have overviews, an overview where you have a printouts of multiple visits that the patient has had with you, and you can have look at the kind of defects. And here is what kind of a defect do you see? There is a scotoma in the temporal part. Yes, it's a temporal wedge defect. Now most of the glaucomatous defects are in the nasal periphery, but if you get something in the temporal periphery, it's unlikely to be glaucomatous, though there could be glaucomatous defects also in the temporal quadrant. So most of the defects are in the nasal to the disc, either nasal steps or arcuate scotomas or paracentral scotomas. But if you see something temporal to the disc or temporal to the blind spot, then obviously there is some other pathology. Yes? So this is a temporal wedge defect, and what you see, is it increasing? It's more or less decreasing over a period of time, and more or less it has disappeared now. So what has happened? What has happened? Why did that visual field defect disappear? Learning effect. Okay, this patient is trying to learn. He doesn't know how to do a perimetry. He was trying to learn, so he had a defect, and over a period of time, as he learnt, the visual field defect disappeared. And again, an overview of a 10-2. Okay, this shows how a 10-2 also is changing. There is this particular visual field defect. This patient was young. He was brought to us. He was on treatment for glaucoma, and you could see that there is something like an arcuate scotoma here. A glaucoma hemifield test is outside normal limits, and you do his optic disc, and you see, what do you see? Come on, what do you see? It's a coloboma. So that means it is not glaucomatous. He is born with something which is a defect, and therefore does not require treatment. Okay, then there are other types of perimetry apart from white on white perimetry. There was the SWAP, or the short wave automated perimetry. There was a frequency doubling perimetry, and there was a high pass perimetry which was being used earlier, but these devices are more or less not used. You must know that the SWAP uses some psychophysical tests by which a yellow stimulus is provided over a blue background, and therefore there was a very it was a difficult test to do, and more or less has gone out of vogue. The frequency doubling perimetry used a stimulus which was an alternating frequency of high frequency bars that were shown to the patient, and then they were asked to click whenever they whenever they had a doubling of this. This was a very small machine, and it had a very sophisticated version, which was the matrix, again by the Zeiss, but these devices again were not very easily usable. Then we have portable perimeters also. Again, you must know as graduates that a perimetry can now be done on iPads. You don't need that very sophisticated devices. They are also undergoing a lot of tests, and probably will soon be in the market and will replace the Humphrey. And then we have this indigenous device of a perimeter that is being manufactured in India at 1/10 the cost of what Humphrey is manufacturing their machine. So you must be in line with what is happening in perimetry in recent years. The next topic is progression. If I have time, I will go ahead with that. Otherwise, can I? Okay. So then the progression of the disease on perimetry is important. And you can look at how the visual fields are changing over a period of time using the glaucoma change probability analysis. And this is a software which gives you these triangles, right? And these triangles, these dark triangles, tell you that there is some change which has happened in a particular area, and that has to be looked at carefully. So if you have a dark triangle and it is repeated on 2 consecutive fields, it is alarming and has to be looked into. But more or less what is now being used is a visual field index, which is much easier to understand in that it tells you that the patient began with a 100% visual field, and that particular visual field has now changed to more or less like 60%. So it tells you how is the visual field changing, at what rate is the progression happening. Okay, this is important because if you're going to see the patient over a period of many, many years, you have to know what the visual field index is like. And this is an important question because it tells you what is the amount that is lost, what is likely to be lost over the next 5 years, and what is the percentage that is remaining. And based on that, you can make your decisions regarding to upgrade your treatment or not. So this is how a GPA looks like. It takes into account the 2 baseline visual fields that are shown to you, and then it gives you a bar chart here, and here is a patient who is rapidly progressing at a rate of 8.7% of visual field that is being lost every year. And what is considered to be alarming or catastrophic visual field loss? Anybody? How many decibels per year, and you say that it is catastrophic, it is fast progression. Okay, anything more than 1 decibel is fast progression. So if a person who has got 40 decibels and is losing 1 decibel every year, that means it's quite alarming, it's a fast progression. He's likely to become perimetrically blind over the next 10 or 20 years, right? So this rate of progression of 8% is very fast. But then you must understand that when you're looking at progression in a patient of glaucoma, you have to consider that could be a learning effect. Yes? That means that change that has happened maybe just because the patient could not understand how it was done, and I showed you the example of how a learning effect is. You could see how the visual field is improving over a period of time. There could also be a long-term fluctuation. Okay? So this is part and parcel of the disease. A patient of glaucoma will always, especially if he's advanced glaucoma, will always tell you कि कभी मुझे अच्छा दिखता है, कभी मुझे अच्छा नहीं दिखता है. So he'll always say that his visual field is fluctuating. Okay, so that again could be an inherent flaw when you are looking at a change over a period of time. So sometimes his visual field is good, sometimes it's not so good, and again it becomes better. So this is part and parcel of the disease, and it can be an inherent problem when you're looking at fluctuation. Or if it's an already bad visual field. So a patient who has a very bad visual field to begin with, it might not be very easy to understand progression. Okay, in which case then the only way you can find out is by asking the patient, is his visual field or visual acuity actually going down? Then there is no point on doing any particular test. It's only a subjective evaluation of the patient. And then of course there could be other pathologies. This was a patient with near total cupping, and his right eye visual field was progressing, an angle closure glaucoma patient, till he almost lost the central visual field, and we had to look for other causes other than glaucoma for the loss of his vision. And then you found a pituitary adenoma sitting there and causing a loss of his vision. So glaucoma might also be in combination with other diseases. A BRVO or anything that's happened suddenly is not glaucomatous. Okay, you have to look for other reasons if there is sudden loss of vision in a patient. Glaucoma is a slowly progressive disease. Right, so that's all about the perimetry, and I would also like to take an opportunity to tell you guys that we are also specializing in pediatric glaucoma. Those of you who are young minds and are interested in pediatric glaucoma are also invited for this meeting of pediatric glaucoma specialists. We need more people who are young and are interested in this field, which is of pediatric glaucoma, which is more or less underestimated in our country, given the problem that there is a huge problem of pediatric glaucoma. So this is our website of ipgs.org.in, and any of young minds who are interested in pediatric glaucoma are most welcome to be on board. Thank you. Any questions? Yes.